Force on Aging to order for this Wednesday, July 10th, 2024. I believe we're still waiting for one member remotely to have, oh, we're good. We now have quorum. So our first order of business this morning will be to approve the June 18th, 2024 minutes. Members of the task force, is there any discussion to the minutes? Anyone online? Seeing none, all those in favor of adoption of the minutes for June 18th, 2024, please say aye.
Aye.
Aye. Any opposed? The motion prevails and the minutes are approved. Our next order of business will be public testimony. I understand that we have one individual who signed up in advance. If you'd please come forward. When you're ready, if you'll state your name for the record and begin your testimony, please.
There's three of them here. I'm not sure which
Take your
one.
pick, wherever you're most comfortable.
Good morning. My name is Leif Grenna. I am the president of the Minneapolis Regional Retirees Council. We are pleased that the task force will soon begin taking up the important work of determining the path forward to meet the challenge that our aging population presents and that will have profound effects on our state and its people for years to come. I would like to take this opportunity to make one request as you pursue during the coming months the answers to the questions that are in your agenda for discussion later this morning. That is this: elders are the people, the mothers and fathers, the grandparents, the aunts and uncles that will be impacted by the outcome of this process. We are both the focus of the task force's work and a huge asset to our state, the communities we live in, our families and friends, and we are experts on aging. As you have looked into the issues we face, we appreciate the opportunity we have been given to provide our perspective through testimony. But now, as you begin the process of deliberating where you want to go and how to get there, we feel it is imperative that elders have a seat at the table as partners. The task you face is not just about those of us who are elderly. All Minnesotans hope to age. Your work is about a vision for the future of all Minnesotans and how we will realize that vision. The ideal of our democracy is a government of, for, and by the people. The people that this task force is about, our current and future elders, must help craft the vision and the way forward. We want to thank you for the work you have done so far, and we look forward to working with you as you move forward. Thank you.
Thank you very much, and I think your words this morning set the right tone for the conversation that we need to have. I have stated all along that this is a task force about people, which is why you see the task force itself limited in scope so that the voices of the people will be brought forward and not shut out. I want to make sure that we keep the voice of the people front and center in all of our discussions. And as we move forward in the next few weeks, that seat at the table is open. And I invite your ideas, your plans. As I think one of the other testifiers stated early, you know, we are always talked about, but we want to have conversation with. And that's paraphrasing, but it's really important what you say this morning. Thank you.
Thank you.
Was there anyone else that wanted to speak in the public testimony portion this morning? Right. We can revisit that later at the end if we need to. Our first presentation this morning is the Fairview Health Systems. Mm-hmm. And before you begin your testimony, I would like for you just to identify yourself and to please state for the record the position that you hold with Fairview, so that's on the public record.
Absolutely. Good morning. I'm Kim DeRoche. I am a family physician. I also serve as the president and clinical chief of primary care for Fairview.
And I'm John Lundberg, president of Fairview Senior Services and Ebenezer.
Okay. And with that, I understand that you would like to have your conversation a little more conversational. Is that correct?
Yes,
Okay.
please.
So now that you've identified yourself, if you will begin your testimony, I appreciate it.
Thank you.
One moment, please. We're going to work at it, one technical thing.
From this one?
Yeah, okay.
Okay.
Is it advancing?
Tim, just push that button and it didn't, oh.
All right.
Thank
When you're
you.
ready, please begin.
Yes, first I'd like to just give a little bit of an introduction and/or reminder about Fairview. We are obviously based in Minnesota with 10 hospitals, including an academic health center. We have over 80 primary and specialty care clinics. We have 37 pharmacies. We have over 100 senior living facilities. And we not only serve over 34,000 employees, but we have over 4,000 physicians and providers. And this is a representation of our geographic footprint, which is vast. And we serve patients up in Grand Itasca and Hibbing, as well as far north as Princeton and Malacca, and down into Rosemont, Apple Valley, Lakeville, and east to west in the metro. I'm going to tell you a little bit about our ambulatory and primary care delivery services, and John will speak a bit more about the Ebenezer and Fairview Senior Services. And as we start off, although the slide is talking about our geriatrics program, I first want to represent overall primary care, of which geriatrics is a portion. And our primary care physicians and providers serve all ages, but about 20% of the patients we serve are over the age of 65. So we do deliver comprehensive services in our traditional clinical model, including roughly about 18 to 20% of our services remaining post-COVID in virtual care. So we deliver care comprehensively, whether it's electronically, virtually, or in person. But now I'm going to speak a little bit about our geriatrics team in particular. We have a geriatrics team that works within the primary care service line, and this team is based in both advanced practice nursing as well as physician care. So we have 7 physicians and roughly 32 advanced practice nursing providers, including a couple of university faculty which help serve and teach. And then we also use some services, advanced practice providers that help with orthopedic and mental health care to enhance the delivery of the overall primary care. You can go to the next slide. We serve roughly 2,200 patients that reside either in a long-term care facility or in an assisted living facility, and they're served in their facility by our care teams. We also care for a little over 500 patients that receive some of their transitional care in a transitional care setting, so coming out of the hospital with more acute needs before they either return home or to a long-term care or assisted living facility. And we serve these people across about 50 different campuses. So this team is quite mobile, going from different location to different location, and really relying on additional staff, whether it's staff in the facility or some of our own staff to help communicate and coordinate care. And that is one of the things I want to emphasize today, is the amount of coordination that goes into providing this type of care. It is incredibly important to the patients we serve that we coordinate with the facility they live in, and also with their family, their representative, their friend, whoever's assisting in their care, to make sure that we're delivering the care that that patient would want and that that patient deserves. But that coordination takes up at least 50% of the time spent with those patients. So of the total time that our team spends with the patients, at least half of it is in coordination and the other half being in the actual clinical delivery. And it's that part I'm emphasizing because that's the piece of care that's often not well reimbursed, but is critical to ensuring we deliver the right clinical care and the clinical care that that patient would most want. And with that, I'm going to turn it over to John.
Great, thanks, Kim. So Ebenezer is part of the Fairview Health System. We became an affiliate of Ebenezer in 1995. So it's been a long-standing relationship, and we've had a number of years to work collaboratively around different programs, services, resources to serve the older adult populations within the network. And that has come together through improved healthcare monitoring and maintenance resources and services, creating efficiencies in record management that looks at ways in which the electronic records are connected between the acute and the post-acute settings. While still not totally ideal in some of those areas, we have found different ways of being able to work through that in ways that happen because of the relationship and partnership that we have. But it has specifically helped and focused on increased beneficial partnerships and resources across that broad continuum of the physicians, hospital settings, the different community hospital centers, medical centers, primary care clinics, specialty care clinics, our work with health plans, and we'll have some additional commentary about that in a moment here, as well as home care and hospice. So in all of these areas, we've been able to work collaboratively in looking at what are the best ways within our system to be able to meet the needs and address the different services and resources necessary for older adults. With just a little bit of additional background or information from an Ebenezer standpoint, this next slide would depict the different levels of programs and services that fall under the Ebenezer umbrella. So certainly that would comprise independent senior housing, and under that umbrella would be market rate housing as well as HUD subsidized low-income housing as well. Assisted living, which would be the typical or standard assisted living type of community. Memory care, enhanced care, which is the label that we give to programs or services that are provided at a higher skill level within the assisted living community. In some organizations that might be referred to as care suites. Transitional care, which would be short-term rehab, short-term stays for various reasons. And again, in our system, that short-term stay would be about 10 to 12 days. And then skilled nursing being the typical nursing home, skilled nursing care or services. Adult day and child day programs. We have a number of child day programs that are embedded on our different campuses, which allow us to create a whole series of different intergenerational programs and services and resources, which have been a significant benefit to both the older adults we serve as well as to the children that are part of those programs. And then our homeowners association group, which is comprised of our resource services and management to senior cooperatives and condominiums.
Excuse me, before you go on, I just want to make sure I understand the transitional care.
Yeah.
And I'm interested in this 10 to 12 days. So, and this is just an example, and you can say, yeah, that's what I'm talking
Sure.
about, or no, Chair, you've got it all wrong. Okay, so I'm thinking about an individual who has maybe had a stroke, and they go in, they've had their hospital stay, and then they move to transitional care for maybe additional therapy and rehabilitative services. And that's usually, I think, the hospital and that rehabilitation transition stage is usually, what, about 21 days of Medicare payment? Is that the type of service that you would be talking about there? Or is it more, hip replacement, knee replacement, that kind of? I'm just trying to get my head
Yep.
around what that is.
Yeah, a very good question. Thank you for that question. So it would really comprise all of those examples that you're using, and that's why on an average it would be 10 to 12 days. So certainly there would be some individuals that would stay for 30 days or 15 days, but there are other individuals that may be there for just a couple of days. And that may be because they're, certain populations are there to rehab, they're there for therapy, they need some additional medical observation, or it could be that whatever their discharge plan to the community is not quite ready yet. There are some home improvements that need to be made or other sorts of things, and so a host of different kinds of things that like that would impact or that would be part of the overlay for the patients that would be served in that kind of a program.
Thank you so much. I appreciate the
Yeah.
clarification.
You bet. So just, again, to give some additional perspective to that, so under the Ebenezer umbrella, again, we would touch about 10,000 lives on a daily basis, would collaborate and partner with over 60 senior cooperatives and condominiums, and we do that across a 4-state network. Actually, it's a 5-state network. We have South Dakota that should be added to this slide. There are 7 subsidized affordable housing buildings or communities that we collaborate and manage. 37 standalone assisted living and memory care communities, 7 long-term care communities, 5 transitional care programs, 5 adult day programs, and then 4 child day programs, again, that are embedded on our respective campuses.
I'm sorry, I'll just ask one more clarifying.
Yeah.
So of these facilities that Ebenezer is running, can you please tell me, do you own all of these properties or do you have lease arrangements for these properties?
Yeah, so we own some of the communities that are part of this listing here, and some are owned by others and we manage on their behalf. So we work with a number of local developers, local community members who own those buildings and we manage on their behalf.
Okay, thank you.
Yeah. So to give some perspective of the collaborative work that we have been able to do together within Fairview, we want to use an example here of Fairview Partners, of a means of being able to demonstrate the various ways that we come together, leveraging primary care and other aspects of program and service to meet the needs of different groups, nursing or assisted living communities. And then there's the community care model, which focuses on and is directed toward individuals who live in their individual or private homes in the community. So for purposes of our conversation here this morning, we're going to focus primarily on the community care model to give the context of that focus of being able to enable and support individuals maintaining their independence in the community as long as possible. So just quickly to walk through the care coordination model, and I'll invite Dr. DeRoche to interject any comments along the way as we go to any of these pieces as well. So these next couple of slides just will demonstrate the flow and how a patient in this model it would work. So there's the initial enrollment period, the on-site visit, home visit, where the initial 30-day assessments are done, the care plans are developed, assessment for personal care, services are identified, any kinds of referrals are placed, et cetera. So all of that kind of initial introductory sorts of things. Then there are the continuous ongoing pieces of following up and care coordination with that individual. So the regular communication with different service providers that may be interfacing or providing different kinds of programs or services to those individuals. The documentation that happens within the EPIC record, so that all of the providers then are tied into that EPIC record, so all of the communication can flow back and forth, so all the people that are tied to that patient understand what's happening at all times and in all the given situations that they're facing, if you will. And then the different communications that happen at the different transition points that a patient may have, whether that's admission to a hospital, discharge from a hospital to a skilled nursing setting, or into home, the coordination and communication around all of those transition timeframes, which are very critical because it's in those transition timeframes where many times things can get missed or dropped. And so having somebody that's coordinating all those pieces is extremely important and beneficial to the patient. So then moving on from there is the ongoing review, the 6-month follow-up telephone screenings that occur with those patients through the case management that would be looking at different types of updates that maybe are necessary in terms of their goals for their plans of care, different kinds of supports that they may need, reviewing of recent falls or other preventative care needs that may be necessary. So looking at how to maximize those preventative measures to avoid other issues down the line. And then there is an annual home visit that would then look at and assess all of the different critical care-related kinds of issues or clinical-related kinds of issues, but it also brings that care manager into the individual's home so they can see where that person is living and understand how that may be impacting their the kinds of needs that they may have, and to integrate any of that in that as well. And that whole process continues to flow as long as the person is enrolled in the program. There currently are about just under 5,000 members in the Fairview Partners network and enrolled in those different pieces of the program. And then certainly disenrollment would happen at the time of death, or if somebody is changing their health plan or moving to a different provider group. Otherwise, the flow here just continues to repeat itself or flow through that. And to Dr. Roche's earlier commentary about the significance and importance that care management plays in being able to support and sustain and help individuals maintain in the community environment is critically important.
I'll just stop you for 1 second. So right now you have about 5,000 individuals.
Yes.
Are you at capacity? Do you have excess capacity? Are you over capacity?
Yeah. So we could expand capacity. The capacity is limited by the volume of patients that a care manager can manage. So as the capacity would grow, we would add care managers to meet that capacity. So it flows based on the number of care managers we may need.
Okay, and then one other question about that. Is there a portfolio mix in that 5,000 individuals? So do you follow a strict formula of X number of private pay, X number of Medicare doesn't do this, but you know what I'm saying?
Yep, absolutely. So the Fairview Partners is a program for dual eligibles, so Medicare, Medicaid certified individuals. Thank you for pointing that out. I forgot to mention that. So it would cater to those individuals who rely on government resources to support and to be able to then subsequently assist them in navigating and managing their cares.
Right. Thank you very much. I appreciate that.
There's some additional wraparound services that are part of the Fairview Partners project as well, and that would include, let me move to the next slide. That would include geriatric certified pharmacists, so to be able to look at and review pharmacy prescriptions, particularly at times of transition, post-hospitalization, et cetera, and to collaborate with primary care and other resources such to determine that the pharmacy continues to make sense. In-home advanced care planning visits, so somebody that would come to the home to have some of those conversations and help somebody contemplate or look at how they would want to manage that advanced care planning process. And then pulling together the interdisciplinary team for those case reviews and looking at the broad picture in terms of that individual, that patient, and being sure that everybody's on the same page in terms of what the plan and process is. Also, community health worker is part of it, and this is one of the resources that would also assist members in terms of looking at housing assistance they may have, gaps in care outreach, assisting them or supporting them if they're needing to make medical assistance applications or renew some of those documents, et cetera, but providing some of those supports and helping them navigate some of those details that can sometimes get lost or can be terribly cumbersome and confusing for individuals. And then just basic support staff that will help in scheduling appointments, arranging transportation, and those sorts of things. So all of these pieces are just incredibly important in terms of being able to support and assist individuals within the community setting to focus not only on the care aspects of the needs that they may have, but the social determinants of health as well. Those sorts of things that care managers can also help those individuals navigate to see that they've got that broad array of resource and support in that community setting. These would be the types of programs that we would encourage the committee and the legislature to continue to look at and strive toward finding ways of being able to expand, enhance, and developed to ensure that those resources are really there and present for individuals.
Okay, and then I'll just ask you, just for the sake of making sure we're all on the same page, you use the phrase advanced care, which may mean different things to different people. Could you just give us a snapshot of your definition of advanced care?
Yeah, so it would just be ensuring that individuals, their life plan issues are clearly articulated and understood, what, in given situations, what kinds of cares they would want and would not want, and
So
how that would all play out.
DNRs, do not intubate.
Yes.
These are my choices.
Exactly. So again, making sure that everybody's all on the same page and understanding that correctly, and that the individual themselves has a chance to thoughtfully contemplate and talk that through and understand the decisions that they're making.
And this also includes ensuring we have identified appropriate decision makers should that patient not be able to make their own decisions.
So the DPOAs and people, durable powers of attorney, healthcare powers of attorney. Okay,
Correct.
perfect. All right, thank you.
So now we're going to shift gears here a little bit and move into an area of what are some of the things that are changing in the marketplace, if you will, the kinds of things that are impacting how we go about care delivery, et cetera. So, Kim, I'll let you go.
Absolutely. So some of the things that are continuing to change, of course, are that patients are becoming more acute or more complex. More adults over the age of 65 are being admitted for hospital care. Just in our own hospitals, we see that 38% of our discharges were for patients 65 and older, and that's a 3% increase year over year just in the last 3 years. And for example, at Grand Itasca Hospital and Clinic in Grand Rapids, 43% of their discharges were for patients who were 65 and older. As mentioned before, about 20% of our primary care patients are 65 or older, and the statewide population is about 16.5%, I believe. The other thing that adds to complexity, medical complexity, is the increasing cost of medications and helping navigate that with our patients.
So in addition to that changing complexity, which carries over into a couple of the next categories or areas that we have identified here, is the increased capacity challenges within the post-acute settings. In large part, that is driven by inability to be able to staff in those post-acute settings. And so there's a number of units of service, whether it's wings in a building or certain rooms or whatever, that are not set up for operation just simply because they've not been able to be staffed. And that has particularly been the case post-pandemic. Many organizations did close beds temporarily and/or wings units within their buildings, and have been unable to bring them back into service because of an inability to be able to staff those. That is particularly true in more rural communities where staffing is in many ways much more pronounced, in large part because staff just simply aren't available, regardless of any of the other things that we may be typically thinking of that will bring staff, whether, wages, benefits, et cetera. Regardless of those pieces, there just physically are not people to be hired to fill some of those positions. That, subsequently creates a backlog within the acute care systems because patients cannot be discharged or cannot be discharged timely because there's not an appropriate post-acute setting for that individual patient. When you add that overlay of the complexity then of the patient, there are many organizations or provider groups on the post-acute side that may have ability or availability to admit a patient, but with some of the complexity, they are not equipped to be able to meet the demands of those different patient populations, whether we're talking about extensive wound care, bariatrics, chemical dependency, behavioral health, a host of different things that have become far more complex than they have been in the last 15 and 20 years. That all of that together has created and developed a capacity issue and challenge across the state.
Could you tell me, do you have any idea how many beds have been taken offline in that?
Well, it's somewhat complicated to determine or to specifically say that number. Certainly, there have been a number of facilities that have formally closed or formally closed beds of service, done that through the regulatory process to do that. And those numbers are fairly well articulated in terms of over the course of years, how many beds and services have been taken out. The other units of service that are just not operating simply because they aren't staffed, it's hard to really say what that number is because they're not officially reported, if you will. It's just what an individual facility is doing at a given point in time. So until or unless they would move more to a more permanent closure of those beds, it's somewhat of a fluid number.
Okay, thank you.
In addition to those different capacity issues, there are significantly longer delays with state and or county processes for different eligibility, whether we're talking about medical assistant eligibility, whether we're looking at guardianships or other sorts of actions along that line. All of those processes have taken excessive amounts of time in recent years that really significantly delays discharge from the hospital and prevents timely admission to post-acute setting. So taking the example of guardianship, I'm aware of a specific example within the Fairview system today where an individual has been awaiting discharge, has been in the hospital for 103 days solely because they've been waiting a guardianship so that somebody could be appointed to be able to make decisions on their behalf as well as to be able to access financial information to support them being able to apply for medical assistance. That guardianship has now been approved and that person will now be discharged, but they spent 103 extra days in the hospital than really should have occurred. Those processes are just really caught up in those time delays that may well be staffing challenges in those different agencies of being able to have folks to be able to do that work, but for whatever the reason is, folks then are getting stuck within the system because of those time delays. And then the different rules and regulations that have specifically been in place to govern post-acute settings have not been really updated to reflect the changing patient populations in marketplace. So some of the populations we've mentioned in terms of bariatrics, wound care, other similar types of patients are not the patients that were seen 15 or 20 years ago. And so many of the rules and regulations that were designed around those different populations don't really make sense in terms of these new populations. And that has caused some providers to question whether or not they can and or should be admitting some of these patients based on concerns of regulatory compliance issues that they may find themselves in. Do you have any other additional comments? Okay. So again, I think we would just call out in some specific areas that continue to be challenging here are transportation just in general. And in that case, transportation that certainly might be medical transportation, but it's far beyond that. It's just transportation, period. Technology, resources that will more effectively enable the delivery of care and service, and being able to look at technology in ways that recognizes that as we go forward, the workforce challenges that we all face within healthcare are probably not going to disappear. Just because it's a pure demographic issue of availability of people. And so how are ways that we more effectively can leverage technology and look to see that we are applying staff resources to the kinds of things that we really need hands-on versus other things that could be done in another way. That, again, would address some of the workforce issues and look at the impacts of being able to discharge to home. So then we have a few opportunities or recommendations that we would like to leave with you here. And that first is looking at those payment and care models. So again, similar to the example that we used of Fairview Partners, some things like that, but probably one that we have an immediate opportunity to address is PACE, that program of all-inclusive care for the elderly, which I'm sure that you are well aware of and familiar with. We have the opportunity to push this forward in the next session in 2025 to finally move Minnesota into the forward with the rest of the country and looking at how we can deliver this kind of a program and more effectively, again, meet the needs of community individuals and support and sustain them in their ability to remain as independent as long as possible. So we would just encourage, again, the legislature to continue to do its good work around PACE and see that we finally get that over the finish line in this next session. And looking at sustainable investment in transportation, again, all levels of types of transportation, so that people can ensure that they have access to the resources that they do need, whether those are true medical resources or, again, some of those resources that might fall into that more social determinants types of categories of resources. Technology, we touched on briefly here, but looking at all those different kinds of levels of technology that, again, support and enable the work that is done. And then looking at ways of being able to support and enhance centers of excellence on the post-acute side. So not all providers can do all things for all people. And so how can we more effectively create programs, services, and resources that enable some of those centers of excellence, whether that's for orthopedics or wound care, whatever those different services might be, so that we can find the ways of being able to have the appropriate kinds of post-acute resources so that the flow from the acute settings can happen timely and effectively.
I think I would just add, related to transportation and technology, you know, some of the issues we see, particularly in healthcare, are related to that non-emergent transportation need. If you can get to your clinic or potentially to an urgent care sooner, you know, you can prevent the need for ending up in a hospital or a more acute setting. And so ensuring that we do have that non-emergent transportation that can be timely. Sometimes it's booked out days in advance, and that makes it challenging for people who rely on it. And I think the technology issues are also related to the fact that A, technology is expensive, B, it's advancing quickly, and C, we need to make sure that people can access it, either that they have access to it or that they have access with help navigating it, so that they can reliably use the technology and those services so that they can access healthcare from the comfort of their own home, wherever that may be, when it's available that way, which increasingly it is more and more.
And that is the extent of our presentation, and we certainly would entertain any other questions that there may be.
Task force members, do you have any questions you'd like to ask before we move on? Ms. Schneider.
Thank you, Madam Chair. Thank you, folks, for your presentation today. I have made several notes, so I'm going to go back to your slides so that I can reference them by slide. The first question I had is on slide number 5, where you talk about your challenges and the decrease in the patient volume. Could you talk a little more about that, please?
We have seen a decrease in, the slide references a decrease in patient volume overall since the pandemic. Partly it's related to, I think, what John spoke about in terms of staffing of facilities, but it's also just related to changes in demographics of where people are choosing to reside.
Thank you. Another question I had is on your slide number 6. You talked a little bit about electronic health records and Epic. I'm just mildly familiar with Epic, but I remember in days gone by that there were high hopes for electronic health records. Now, how are there other things that we could still do with Epic or Epic-like systems in sharing information without duplication? How long is that runway? Not to put you on the spot, but I've just been wondering about the electronic health records, because put so much energy into it and money quite a few years ago. What's the return?
I think we can probably both speak to that. Epic has been, and electronic health records in general have been wonderful tools, and they house a lot of information. So that's partly where some of the coordination of care comes in, because it's important that people can sift through the information. If it's not known to them, it may be known to someone else in that record, and needing to be able to enhance how we pull that information out. So that's one piece of the electronic record that's both good and challenging. And I think another piece is just ongoing connectivity between health records, which is a challenge we face in our health system as we care for the older adult population who may reside in a facility that doesn't use Epic, which is what's used in the Fairview Health system.
Yeah, so the Epic is the primary electronic record that's used in acute systems, primary care, et cetera, but it is not used on the post-acute side. So nursing homes, assisted livings, et cetera, would use a different electronic record than Epic. And so to, again, Dr. Drosch's point here, the importance then is in the interface between those two, and sometimes that can be a little cumbersome and clunky for that exchange of information and how some of those things flow. So there are different workarounds that we have created to try to more effectively enhance that and develop it, but it's not 100% ideal.
Yes, I do have more, but whenever you tell me that you're tired. Very good. Very good. I just want to also go to your slide on the living options and services in the beginning of your continuum, and you talked about it, independent living, and you made a reference to that you served in HUD buildings.
Yeah.
So that would be subsidized low-income housing.
Yes, correct.
Quite a few years ago, I felt like that might be one of the favorable ways that we could increase home and community-based options for people who are eligible for subsidized housing by bringing, through the elderly waiver, bringing some care coordination and some other home services. In recent years, I've felt that idea might have fallen a little bit out of popularity. I don't know if it's because of labor shortages, but I'd be very interested in your thoughts about that, because we do have a good number of HUD buildings, especially in some of our more rural communities, and I had hoped that would be a partial solution. Now I'm not sure, but I'd be interested in your take on it.
Yeah, so I would say that this would be an example of where a program like Fairview Partners can play a role in some of those sorts of things. So today, within some of our HUD building subsidized communities, there's a number of those individuals who would be members of Fairview Partners, and so they do have access to those care management resources, some of those other sorts of things that would support and assist them to be able to age in place there. And extend their ability to remain in that setting. So the more that we could look at some of those programs like that, I think that would be helpful for us to be able to do it. and looking at how some things can be set up and established to bring some more services into those communities. We don't specifically provide services in those subsidized housing buildings. I mean, again, they're identified as independent living, but we can help facilitate services to be brought in for individuals into those communities.
I think sometimes a good starting point is to work with the local county HRA, because they have some jurisdiction over those buildings. The other question I had was similar. Just you mentioned that you have 5 adult day. How are adult day programs faring these days?
You know, it still is a challenge on the adult day side. I think adult day is one of those best kept secrets, if you will, in terms of a resource. They provide a great resource to the community. They're financially, they're more feasible, et cetera. But people don't necessarily know or understand them that well. The general community doesn't. So the pandemic was very hard on adult day programs, and so they're making their way back, but I can't tell you that they're back 100% pre-pandemic. But again, I think that there would be further opportunity for us to look at ways that we could leverage programs like adult day programs, which is part of what PACE does. Looks at how you build off of a kind of a adult day type model.
Thank you. I agree with you on that. I would like us to be able to continue to do some work in adult day, because as we think about aging in general as a concept in the state, and we think about inclusivity, and then we look at the reasons why inclusivity is an issue, well, part of it is because our worker shortage challenges. But thinking about adult day, I could be a caregiver for my relative, and I wanted to come to this hearing today, but that relative could be at adult day for several hours, and we could all have, I think, quality. So I don't want us to lose sight of adult day. And then my last question on services, you mentioned community health workers. And I've thought that is another possibly economical boost to the labor shortages. And I'm just wondering if you could expand on your experiences with the community health worker concept.
Yeah, so the way that we utilize a community health worker on the Fairview Partners side is to be able to connect with the members that are in the community and be able to assist and support them, again, if they're having challenges they need to seek different housing opportunities. They're being evicted from their apartment or something, or they've got medical assistance paperwork that needs to be filed. They don't know how to begin to do that, or it's confusing, whatever the case might be. That's how that medical health worker is being used in those cases. Certainly there's other ways a medical health worker can be utilized, but it's in that context that we use that person to supplement the care management, so somebody's world doesn't fall apart because they didn't get an application done timely, and now all of a sudden everything else is cascading in a difficult way, or their apartment building has been sold and they can no longer afford to live there, and they've got to find something in the next 30 days and need those supports and resources, so that we can pull that away from the care managers and not have them get overburdened with some of that work. That's how we use it to leverage that, to maximize people working at their highest potential level.
What do you think about how's the reimbursement rate for community health worker?
Well, it's probably not ideal, but the way that we utilize that in the package that we build together on the Fairview Partners is how we can build it into the overall component of that. So if we were just doing that community health worker as an independent resource or service, probably would not be a sustainable model, but it works differently under an umbrella like Fairview Partners.
Understand. Thank you very much, Madam Chair, for the time, and thank you, folks.
Ms. Foley, you have a question, and then Dr. Gogler has 1 or 2 questions. Ms. Foley.
I had a question about your enrollment and assessment for your community care model. I do all that with MA through through MA with myself, how does a person know that they're eligible for all that? Do you have to be in a setting to get it, or can a person just come to you and ask for an assessment, or how does that work? How do people know that they can apply for all that information?
Under the Fairview Partners.
Okay.
So first off, in that resource in Fairview Partners, they have to be enrolled in Fairview Partners. And
Okay.
so through the enrollment process, then they would be made aware of those different resources and services. But then the ongoing care management would also, as they're making their regular contacts and connections with those members, that they would understand or know where some of those different kinds of issues might be. If there is a MA application that's due, or some of those different details or resources. So sometimes it's even more so than that the case manager may be bringing it forward to the member versus the member themselves saying, I've got to submit this and I don't know how to do it, but reminding them that October is when you have to do this, or this time frame. But it first starts with being a member.
Okay.
Dr. Gogler?
Yes, thank you. Thank you, Fairview, for that presentation as well. Two comments, actually. One based on Ms. Schneider's question related to housing and coordination and such. Again, I wouldn't expect anyone to remember this, but if you recall, I had shared early on in the task force meeting schedule that report that came out by AARP of 6 scalable innovations that are ready to be scaled and disseminated. And Ms. Schneider, one of them indeed was in fact integrated housing with services, and the models that were presented by AARP that have shown positive results actually were taking place in Vermont and some other states as well. I mean, for us as a task force, it may be again worthwhile for us to reflect on some of those innovations that could be ready to scale. We've already reviewed multiple of those innovations already: Green Homes, PACE, Capable, but the housing with services was one of those other innovations in that report. The second thing too, and I don't know if time will permit today in our meeting schedule or not, but it's related to the presentation and the need for a reimbursable care coordination. And just earlier this week, I don't know if anyone has been paying attention, but the Center for Medicare and Medicaid Services, they released the over 300 healthcare providers that now are going to be providing the guide model. And if you recall, the guide model is a collaborative model of dementia care that it operates through primary care, that Medicare will now reimburse for services, including care navigation, care coordination, and caregiver respite for both beneficiaries who are living with dementia as well as their care partners, whether they are a beneficiary or not. And there are 5 sites in Minnesota that actually were named guide model sites. I was actually hoping to see more, certainly when compared to some other states of similar size. But nonetheless, if time permits, I can share with you who those sites are. Again, when you think of a model and an ideal collaborative care model that would work for older adults, not just living with dementia, but other complex conditions, it's a model like the guide model I would consider would be best practice.
Thank you,
And
Dr.
again, it's
Gogler.
something, and I'm sorry, excuse me, Chair, I'm sorry. And it's something that I think, as our task force, as we continue to refine and move towards finalizing our final set of recommendations, it's something I think we should consider and incorporate in that final report.
And Dr. Gogler, I think it would be a good idea for us to include that in the materials that are available on the website as well. Thank you. And I think with that, we have concluded our questions for you, and we'll move on to the next item on our agenda. Thank you so much. I greatly appreciate your being here, and I'm sure this just is the beginning of a conversation. So thank you.
Thank you.
Thank you.
Our next item on the agenda will be Health Partners, and I believe we have 4 individuals coming up with Health Partners. And we can pull up another chair also. Oh, just 3? Okay, perfect. I had 4 names on my list, so, okay. Thank you. And again, we'll do kind of the same thing. If you'll introduce yourselves, who you are, And because we have two of you, when you speak, if you'll just say, this is doctor, or this is so-and-so, that way in the record we'll know who's actually speaking, all right? If you would please state your names for the record and your position with Health Partners, then we can move forward.
Thank you, Chair Cleavorn and members of the task force. I am Dr. Chrisanne Timpey. I'm the medical director of the Hospital at Home program and a hospitalist within the Health Partners system.
And I am Dr. Jerome C. I am also a practicing hospitalist at Health Partners, and I am the Associate Senior Medical Director of Value-Based Care and Home and Community Services.
I'm Tia Radent. I am a Director of Hospital at Home and our Community Paramedicine Program at Health
Awesome.
Partners.
And then when you're ready, if you'll just state your name and begin your presentation, that'd be great.
Sure. All right, this is Dr. C. First, I want to thank the task force for this opportunity to speak with you. We are really just delighted to be here and to be able to share with you some of what health systems across Minnesota are doing to meet the needs of our aging communities. With challenges to affordability, workforce, and access, the healthcare needs will not be met unless we create a sustainable, age-friendly healthcare ecosystem that's designed for our aging communities. The three of us here are from Health Partners, where we encourage innovative care models to meet the challenge of quality and affordability, and for our aging population, it is no exception. Diverse programs like our Orthopedic Healthy Aging and Fracture Care, Neurosciences Center for Memory and Aging, and Geriatric Community Senior Care have for many years focused on it and provided attention to the health and well-being of our aging population. Yet these are not enough. Today, we'd like to share with you another care model that is gaining momentum across the country and has demonstrated better quality and experience for seniors of all walks of life. Along with the Stratus Health Acute Care Working Group, we believe providing acute care in the home, often called hospital at home, will lead to greater affordability of healthcare services and help connect programs within the healthy aging health ecosystem of care.
So on your screen, you'll see a schematic that we put together that shows some of the programs that we champion at Health Partners. The one we will be talking about today is Hospital at Home, which is in the middle on the bottom, but we wanted to emphasize that it is a piece of a greater ecosystem, and all of these pieces rely on one another to deliver excellent care to our seniors. Hospital at Home is a care model that is designed to replace a hospital stay with care in the home. So somebody who is sick enough to be admitted to the hospital, rather than going upstairs to a room in a brick and mortar building, would go home and receive their hospital care at home. So we really do strive to meet the standard of care, and studies have shown that outcomes are better or improved for folks who are enrolled in these programs across the country. We'll do things like IV medications through intravenous lines, daily lab tests. A hospitalist will see a patient every day for medical decision-making, and the team will be in the home delivering care. This is just to emphasize, it is not post-acute care. It is not home care in the traditional sense. It is hospital at home, 7 days a week, 365 days a year, and 24 hours a day. An example of a patient who might benefit from this care model is shown here. This is one of our earliest patients. I like to go back to him because in a lot of ways, it's the same program as it was back then with some additional technology along the way. This was a gentleman who had dementia, but was really thriving at home with the help of his family, had some comorbidities like heart disease and diabetes, and ended up with an infection. His primary doctor tried to treat it in his home with medications by mouth, and it wasn't working. When he went to the emergency room, it was recommended that he be hospitalized. But in this case, his family said, there's got to be another way. If you separate us from him, he'll become delirious, he might fall, we'll be separated and isolated, and his sensory impairments are significant enough that he really can't do this without us. And so he actually did meet criteria for this program, and it was enrolled in Hospital at Home, where he received all of the things that we would have given him had he stayed in the hospital. Medications through his IV, daily labs, daily rounds by a physician, and he successfully avoided an overnight in a hospital bed. So CMS in 2020 signed a waiver that really helped galvanize this movement across the country. It really allowed people to try this and to make it more accessible for organizations. And so over the years, since 2020, over 250 hospitals have applied for this waiver and are practicing this model of care. Research that was published by MedPAC in October of 2023 included a review of 16 research trials that compared people who get their hospital care at home versus in a brick and mortar hospital. And really, mortality was comparable. Readmission rate was a lot lower for people who received their acute care at home, and the cost of care was difficult to assess, although other studies have shown that a trend toward less cost when the care is delivered in the home. In current state, there's a lot of variety in how this is reimbursed. So Medicare fee-for-service does reimburse this. Medicaid varies by state, and some private insurers do reimburse this model. At HealthPartners, we have cared for over 800 patients. Our mortality was 1 out of 800 patients, so lower than the traditional hospital, and our readmission rate is 33% lower. So in other words, people end up back in the hospital a lot less often through this program. You see some other demographics there about the patients that we've seen, including 8 Minnesota counties. So we like to talk about the 3 R's when we're telling people about this model of care. One is research. So there is quite a lot of research on hospital at home model of care nationally. And actually it was championed in France back in the 1960s. And so worldwide it is a known entity. We're a little bit late to the game here in the US, but we still are seeing promising results. Acute care can be delivered outside of hospital walls. And we would argue that for certain populations it should be and is probably a safer alternative. Real estate is the second R. So our hospitals are already struggling with capacity. I can tell you this as I just walked up the hill from Regents Hospital and the ER is overflowing. We already are having challenges, and as the population ages, this will become even more challenging. And then the return on investment really is significant. We are delivering high quality care in the home, but really importantly, patients and caregivers are thrilled. They're happy to be home with the trappings of their dogs, their family, the comfort of their own bed. So when it's appropriate, it really is a preferred model for a lot of patients. At this point, what we're hoping to talk with you about is really how do we make acute hospital care at home or hospital at home part of state program benefits? Is this something that can be discussed? And how do we support strategic use of healthcare workforce? So just like this was discussed with the Fairview group ahead of us, workforce is a big issue. Who should be doing this work and how do we expand the care team? Especially knowing that folks who deliver this model of care do report improved joy in their work and job satisfaction because of the variety that it offers. And then we really just wanted to broaden everyone's understanding of acute hospital care at home as conversations continue.
May I interrupt just a moment? Okay, so this whole idea of who should be doing this work, and the task force I'm sure may have questions about this towards the end, while there could be greater cost efficiencies for the systems, that doesn't necessarily mean there are cost efficiencies overall, right? There is no free in this world. Somebody's paying somehow. Do you want to address that now, or do we want to put it in a parking lot for later?
I'm happy to
Okay.
share some thoughts. From a utilization, this is Dr. C.
Thank you.
From a utilization perspective, we use the same criteria for inpatient management and partnership with our payers on that overall scrutiny over use. And so from an overall utilization perspective, we would expect it to at least be the same. There's always that concern about adding cost to the system. And this is meant to be an option and a replacement, so it doesn't add costs. Overall, though, if quality has improved, mortality rates are lower, utilization rates are lower, readmission rates are lower, falls are lower, secondary infections are lower, we would expect that overall healthcare costs should actually decrease.
I just want to, So I'm thinking about the unpaid labor force, right?
Oh.
The family caregiver.
Yeah,
The,
yeah.
I mean, somebody's doing that care. Somebody is with that individual, right?
Right.
So I'm thinking about my own experience. I'll just throw this out there. I remember walking in as my mother-in-law's post-knee replacement care provider. And I remember walking in and seeing her leg for the first time and thinking, holy moly,
Yeah.
I'm out of my depth, right? This looks way more serious than I thought, right? It went well, everything was good.
Yeah.
So yes, it did get her home faster. It did get her the care supervision that she needed. Yes, there was somebody that she then later called an expletive, making her do her exercises, right? All of these things happen, right? But that
Yeah.
is unpaid caregiving.
Gotcha.
Right? I took 2 weeks to go and be with her and do that work 24/7.
Thank you for that clarification. Actually, Dr. Timpe, would you like to talk about criteria for being able to be
Yeah.
at home and what our expectations are of family
Yes,
caregivers?
so thank you. This is Dr. Timpe again. That's a really important question, and nationally, it's a really hot topic in the hospital at home community. So how do we support caregivers? And there is a lot of innovation in this space. So rest assured, you're not the only one concerned about this. At HealthPartners, part of the enrollment process includes this very discussion. So the care, we never enroll a patient without discussing with their caregivers. What we have found, very honestly, is that usually the caregivers want it. And I'll say, we'll only be in the house for X number of hours a day. How are you going to feel about it? And in general, people say, I would rather have him home with me where I know him and I can care for him than have to schlep into the hospital over and over again. So we are hearing feedback from patients that they want to be part of it. We are also looking for ways to help support them, either financially or physically support them, so it's not always just them. And it is an ongoing, it's an evolution, for sure.
Yeah, and I think that's the piece I just want to bring to the conversation, right? And we can have, this is something that we need to factor in, right? So as we're thinking about what that caregiving looks like, and as we are facing workforce shortages all across all industries, right? Not just in healthcare. So when that, and we, as a family, made those very same decisions, right? Let's get mom home, let's get mom cared for, let's get her where she's comfortable. She will be way more compliant, with a family caregiver. We knew that. But there was, so for the work that I was doing, now shortage, right? So we have to try to figure out how we're going to balance all of this, right? And so we can move on with your presentation, but I just want to make sure that when we're talking about costs, we're looking at all the costs.
Correct.
Thank you.
That's right.
Right.
The last piece was we created a double-sided document for you. If you do have questions about some of the data behind this nationally, there's a QR code on the back with a 3-minute video of our program that sort of describes the program and gives some patient testimonials. Please reach out to us with questions about really anything you see here. And we really importantly wanted to bring up, to final end with really what's the state of hospital at home care in Minnesota, which you see on the bottom there. And the reality is there are only 2 healthcare systems who are actively delivering this model of care, and it's essentially within the metro area. So when you hear our Fairview colleagues talking about 43% of hospital discharges in rural Minnesota are over 65, we're missing some major opportunity for our aging population with programs like this. I think we could probably help a lot in those settings as well. And so rural and underserved populations really are lacking access to this at this point. So we're hoping to expand that.
No, that's an important, that's where we're seeing the largest gaps in all of this conversation. Task force members, do you have any questions? Ms. Schneider?
Thank you, Madam Chair. Thank you for your presentation, folks. One of the questions that I was going to ask you had exactly to do with that, the rural underserved communities. It says that you have 8 Minnesota counties, and I assume that those would be in the metro. So what sorts of challenges then would you be seeing in building partnerships with the rural, besides some of the obvious? What are you finding?
Yes, this is Tia Radent. Well, thank you for that question. There's probably several factors. First, we think about the role of technology and how we can expand high-quality telecommunications to certain areas where the physician role could be done by video. I think it's a workforce question, which unfortunately we know is a challenging one, around being able to physically get folks out to the different homes in different parts of our state. There are several programs around the country who are currently piloting some rural hospital-at-home models with different elements of technology and workforce combinations. And we are HealthPartners and the rest of the Minnesota Consortium is part of a users group across the country to learn from each other so we can understand best practices and grow from each other's successes. So I think in the future, it's about understanding what this is, having a payment model that is sustainable. The CMS waiver is set to expire at the end of this year. There's anticipatory extension of that waiver that we hope we will see. And then having health systems be able to embrace technology and sort of a different type of workforce to be able to deliver this kind of care. Again, hospitals will always have a role for acute care, but there is some acute care that can be done in the home. And I think those are the areas that we'll need to expand.
Thank you. Madam Chair, I did have one other question if we have time.
Ms. Schneider?
Thank you. Maybe this is on your two-sided sheet, I don't know. I didn't really get a chance to look at it in detail, but I just wondered, do you have comparison data in terms of average length of stay for a hospital-at-home patient versus a traditional hospitalization?
Do you want to?
I can answer that.
Our average length of stay in our hospital-at-home program is 4.5 days. And for a similar population in our hospitals here in the Twin Cities, it's about 5.1. So we're very close. You'll see data both directions, both longer and shorter across the country. We also do a post-acute continuation of visits. So after they're discharged from hospital at home, we continue to see patients in the home. And programs that have those, I think, have a shorter length of stay.
So that would be different than a traditional hospital stay where there wouldn't be that follow-up then?
We offer it to both, but yeah, it's built into our program.
Thank you very much.
Dr. C?
Yeah, this is Dr. C. I'll just add, if you've heard some of the comments earlier, recall about care coordination and care management post-hospitalization, it's similar to that in that we want to provide ongoing eyes and ears to make sure people remain successful even after the acute episode has completed. So in that same vein, our program wants to keep eyes and ears on how an individual is doing after the hospitalization is completed. So it's in that same spirit that we want to continue having some closer connections to make sure folks have really been able to transition out of that acute phase.
Thank you.
Thank you. Ms. Foley?
I just had one question. Well, you have 800 patients in your program currently. Do you actually see all 800 in their home every day, or is a lot of it telehealth?
Thank you for that question. This is Dr. Timpey. So just to clarify, we have cared for 800 patients in the program. In a single day, we do see every patient who's in the program at least once, oftentimes more than once. And we do leverage telehealth for a lot of the clinician visits. So for example, if I'm rounding in the hospital, I might see patients in the hospital and get on a screen and see a patient in their home. It's part of our daily rounding census.
So I just want to clarify that. So the majority of the doctor's visits are virtual. Is that what you're saying?
Yes.
Okay. Ms. Foley?
But somebody does go to the house each day.
Yes.
Okay.
Dr. C, you
This is
wanted to
Dr.
add to
C.
that?
I wanted to add to one of your previous questions, if that's okay, around
Please.
rural populations and communities. I think one of the other, I wanted to add this challenge around regulation. You know, the current models that we work under are in the spirit of CMS and the waiver that they provided. But that is contingent upon other regulations that hospitals have that then just have to get extended into the community. So for example, the manner in which medications are procured and then delivered. If a rural community is unable to procure medications directly from a hospital and then brought to the door, rather than potentially retail or even use of their own home medications, those kind of things become barriers in communities where resource and access is limited, not just by the hospital care, but all sorts of other providers of healthcare in the community. And so that type of regulation can also be barriers in communities where resources can be limiting. Yeah.
So what you're saying, I just want to make sure I have this right. So instead of the patient receiving individualized bubble package, this is for day one, this is for day two. If they already have the medications in their home, these are their standard medications they've been taking for decades, you're suggesting it would be less expensive for us to allow them to just do their regular medicine with the 90-day purchase that they have been doing for decades.
Yeah, that's right. And even if, for example, if I was prescribing an intravenous antibiotic or a new oral medication, I only have limited places where I can procure the medication before it gets dispensed to their home, rather than the corner drugstore, where we can get that. And so those kinds of limitations in rural communities may make it harder to develop these kinds of programs.
Okay, so this is kind of a deep in the weeds question about that then? Okay, so again, about who pays, who benefits, right? I know with some of our pharmacy, benefit manager situations, could this possibly also then put a hardship on the local pharmacy if they don't have a decent reimbursement rate for that medication that you are? Like I said, that's a deep in the weeds question, but.
Yeah, that's a really great question. Do you actually, yeah.
Yeah, so I think that's a great question that's probably unanswered, and one of the issues with expanding to rural populations is, so today, in the hospital-at-home rules
Right.
for how it's being delivered, everything that's delivered in the hospital has to be able to be delivered in the home.
Correct.
So if a patient needs a meal, we can provide a meal. Every medication comes from the hospital pharmacy. Everything that we are doing, it has to be replicated. And so I think when we think about rural expansion, it's not just about making the rules more applicable to the local community's resources, but being able to creatively think about that. And so the reason you're gonna get the same medication you've taken for 3 years from the hospital pharmacy is it's part of your hospitalization, right? And how we bill in that world. But when we think outside the box even further, and we think about expanding this to areas where that might not be feasible, I think a flexible payment model also makes sense.
I think what you're saying makes a lot of sense. I'm just trying to grapple with the current system that we have.
Yeah,
Maybe not the
exactly.
system that we want, but the system that we have. And what's in the state control and what's not in the state control. Is there any fear that the CMS waiver would not be renewed?
Well, the last I heard was there's anticipation that it will be extended. It's about how long it will be extended for the next study period, because we want to make sure we're studying the model. And so I think the question, what they've heard on the Hill is not so much whether or not people are in favor of extending, it's how long it would be extended for.
Awesome, okay. Any other questions online? Okay, seeing none, I'm going to thank you very much. This is very informative, and I appreciate your indulgence with my questions as well.
Absolutely.
All right.
Thank you.
Thank you so
Thank
much for
you.
being with us today. And for the QR code, for anyone who is interested, it's on the handouts that would be in the packets today. Okay, our next presentation will be from the Minnesota Optometric Association. Yeah, when you're ready, if you'll state your name for the record, and then begin your presentation.
Thank you, Chair Claiborne and members of the task force. My name is Dr. Nicole Schmidt, and I'm an optometrist practicing in Lakeville in a private optometric practice. I'm also a member of the Minnesota Optometric Association. I provide comprehensive medical eye care services as well as low vision rehabilitation. As a low vision optometrist, I'm particularly aware of the challenges that face our aging adult community as they aim to remain independent and active in their daily lives. Today, I want to provide some background regarding vision loss and the aging population. I will also expand upon 4 recommendations I have for the task force. As you plan and implement recommended policies for aging Minnesotans, I urge the task force to consider supporting health coverage and access for seniors to receive comprehensive in-person medical eye exams once yearly, To consider encouraging access to low vision rehabilitation to close the gap that exists with these referrals. To consider providing appropriate funding for Minnesota State Services for the Blind and Visually Impaired, as well as other nonprofits such as Vision Loss Resources. And to consider researching and investing in innovations to sustain the engagement of older adults in the community. Before I dive into each of these in detail, I'd like to give a brief overview regarding vision loss and the aging population. As you know, Minnesota's population of 65-plus individuals is growing rapidly, with the largest increase happening now from 2020 to 2030. According to the 2021 National Health and Aging Trends, 1 in 4 older U.S. adults have vision impairment, and as the U.S. population ages, the number of individuals with vision impairment is expected to grow. The prevalence of vision impairment is expected to increase 24% per decade over the next 35 years. Vision impairment is known to limit independence and creates numerous barriers to engaging in everyday activities, community participation, and maintaining well-being. Vision impairment is also known to increase the incidence of many other comorbid health conditions such as depression and anxiety, risk of falling, and cognitive disorders such as dementia. However, vision impairment is considered a modifiable risk factor in these conditions, meaning that if vision loss can be prevented or treated, the incidence of these health conditions decreases. This leads me to my first recommendation. If the risk of mental health disorders, falling, and cognitive impairment all decrease with decreasing visual impairment, Minnesotan seniors need access to low-cost quality eye care to help prevent and treat vision loss. It's estimated that 90% of vision impairment and blindness globally are avoidable, and a large majority are treatable with low-cost and widely available interventions like cataract surgery and eyeglasses. The task force needs to support policies that reduce the cost of eye care for seniors, especially the cost of glasses. Adequate correction of refractive error with glasses reduces the prevalence of blindness by 20% and visual impairment by 37%. Equity should also be incorporated when designing these policies so that 65-plus-year-olds with low income, low education, or that live in rural areas can also be included. It's important to keep in mind that rural Minnesota tends to be older on average, and this population is more likely to have reduced access to care. These are often the most underserved in the population, as out-of-pocket costs are a major barrier to eye health care. The next step, and my second recommendation after routine care, is making follow-up care a priority. If vision loss is discovered during an eye exam and cannot be corrected by standard glasses or medical intervention, it's the standard of care to refer a patient to a low vision rehabilitation optometrist. There's a large gap in the healthcare system for older adults that need low vision care. Low vision optometrists are unfortunately a scarce commodity, and patients often have difficulty finding a provider or traveling to the provider for care. The National Nursing Home Survey in the U.S. discovered that only half of nursing homes contract for vision and hearing services, and only 12.6 have optometric services available. Access to eye care is important in maintaining independence and quality of life in the care home setting where residents are dependent on their caregivers. If a patient in need has been diagnosed with vision loss by their eye care provider, has been appropriately referred to a low vision optometrist, and successfully accessed low vision care, this is often just the start of a long-term rehabilitation process of adjusting to life with vision loss. Our society has been developed for sighted people, and navigating the complexities of employment, transportation, and activities of daily life all need to be relearned to function efficiently with vision loss. This is why my third recommendation is to support and expand funding for Minnesota State Services for the Blind and Visually Impaired and other nonprofits such as Vision Loss Resources. These organizations take the next step and help keep visually impaired people integrated in the community. For example, the World Health Organization recognizes employment as a paramount social determinant of health that influences well-being and quality of life. Without workplace accommodations, visual impairment can make work more difficult or even impossible. Without workplace even when employed, people with low vision impairment earn less money than those without vision impairment. From the Canadian Longitudinal Study on Aging, visual impairment is correlated with 3 times higher odds of not working than those without visual impairment. Therefore, workplace accommodations are crucial to help keep those with visual impairment in the workforce. Some examples of common accommodations are modified work hours, modified workstations, and working from home. These accommodations are often fought for by visually impaired people in conjunction with advocates in vocational rehabilitation at Minnesota State Services for the Blind and Visually Impaired. This crucial service keeps Minnesotans in the workforce and results in substantial gains in productivity for the economy. Policies to support vocational rehabilitation services and to improve workplace participation by those with vision loss are needed. Finally, I urge the task force to continue to research and invest in public innovations to sustain the engagement of older adults in the community. Functional limitations to vision lead to a loss of independence, which restricts many people to their home, leading to loneliness and social isolation. Support is needed to assist with independent activities of daily living to encourage aging in place, quality of life, and well-being. There are many innovative technological solutions to improve the lives of those aging with vision loss. Some examples include screen readers, magnifiers, scanners, and navigational canes. Personal smartphones and computers also have integrated accessibility tools like enlarged text, text-to-speech, and enhanced contrast. These can all be implemented and adopted with the help of a low vision optometrist. Other challenges reported by individuals with vision loss were lack of accessibility and transportation barriers. Website accessibility or lack thereof is a central issue facing people with vision loss. There are known solutions to make online content accessible, such as minimum contrast standards, text resizing capabilities, and screen reader accessible content. In 2022, the Americans with Disabilities Act specified that websites and mobile applications are considered places of public accommodation. Therefore, local and state governments, as well as businesses open to the public, must provide accessible web content. There's a clear need to make existing technologies accessible for people with vision impairment, specifically making websites compatible with screen readers. Broader mandates and policies that enforce and incentivize the development and maintenance of accessible web content are needed. These policies can also apply to transportation. Mobile apps for public transit that offer real-time transit information in an accessible format are an invaluable opportunity for those with vision loss. App-based ride services such as Uber and Lyft also provide enhanced independence for the aging population and should provide accessible information as well. So as more and more Minnesotans continue to age, more will face these everyday challenges of life with vision loss. I urge the task force to consider the importance of annual in-person medical eye exams for seniors that include materials benefits for glasses or assistive devices. These exams will help diagnose vision loss early in order to treat it most efficiently or to start the process of adapting to vision loss. I hope the task force will help prioritize low vision rehabilitation for seniors with vision loss and plan on investing in resources such as Minnesota State Services for the Blind and Visually Impaired. Finally, I hope discussion and research will continue so innovative technological solutions for the public, including accessible websites, public transportation apps, and community education for our visually impaired population can be incorporated into our communities. Thank you.
Thank you. I really appreciate the thoughtfulness of your presentation today and your focus on the real needs that ordinary people have, right? I know what it's like when I get downstairs to get my coffee and I realize I've forgotten to put on my glasses, right?
Yes.
I can see to get to my coffee, but I can't see to make it.
Right.
So, these are the real life issues that make us start our day in a positive way or not. And the focus on helping people stay present and viable and vibrant in their lives is really critical. And so thank you for the work you do in the low vision world. I appreciate it. Ms. Schneider, did you have a question?
Thank you, Madam Chair. Thank you for your presentation, Dr. Schmidt. Just thinking about the rural for a moment again, and your recommendation number one, that we would have annual eye exams in person. So the obvious question, of course, would be the transportation, but that leads me to ask you about the portability of annual eye exams and how that might be coming along nationwide. Is it feasible? I remember it from many years ago. This is as a child. We're talking many years ago, where you would actually go to a portable unit somewhere on the main street, and the optometrist would be there for a day or a few hours. So just wondering how that model may or may not have evolved to serve the rural population.
Yeah, that's a fabulous question. And I think the main point that I learned when I was researching topics to talk about is that there are many options available for vision screenings and simply testing vision or determining the level of vision of someone, maybe in a rural community. We have a lot of these mobile eye exams that can go out to a location for a day and screen everyone. But it really is that follow-up care that's the most crucial, and getting in for that follow-up care to provide additional treatment, as well as these low vision rehabilitation services, that's the most important. What I love about optometry is generally there is an optometrist in these small local communities. And so I think that there is that level of care out there. It won't need to be hard to find, but it is getting the patients into the office in order to receive that best follow-up care.
And I'll just add to that, I've often said at the Capitol, and you may have heard me say this previously, oftentimes the only medical provider which is close to the patient is their pharmacist and their eye doctor.
Yes.
And making sure that that quality of care continues is a priority for me. Ms. Foley, did you have a question? Okay, and do we have any questions online? All right, there are none online. Thank you so very much
Thank
for
you.
being with us today and for your thoughtful presentation. And if you haven't provided your written testimony, we would really appreciate having that
Sure,
as well.
yes.
Thank you.
Thank you.
Okay, members, I tend to let things run a little long in the presentations, and we always have questions that we have made public for our discussion. And I know that you've received these questions in advance. So I'm thinking about the work that we have yet to do before us, and the ultimate duty of the task force is for us to determine the governmental entity to plan, lead, and implement. And today in testimony, we also heard that the public wants to be at this table as we have this discussion going forward. So we need to think about who is actually going to recommend the policies and funding for aging Minnesotans across our state. Under this duty that we have, what result does the task force want to achieve? You know, what is our ultimate outcome there? And how do we want to go about doing that? So what is the outcome that we want as we do that ultimate duty? And then what process do we want to go forward with? Thoughts from the task force members? And Dr. Gogler, I see that you're looking very thoughtful. Do you have comments?
Yeah, I mean, that's a big question, isn't it? I mean, that's kind of, Chair Cleaborn, you've raised the core question for our task force. You know, I think with such a large question, to me, the beginning step is what are the core principles and that we want to guide the work in the report. Certainly, some of the things that you've mentioned today, and I think have been apparent throughout all the meetings, is this importance of community partnership with communities and older Minnesotans themselves, as well as their families and professionals, when shaping any recommendations and implementation of those recommendations. I mean, that to me would be one of the core principles guiding our eventual report and recommendations. Probably another core principle that I think we've been hearing again and again is the need for coordination across different entities and a singular entity in place to do that. And then from there, I think once we have those core principles in place, then the other elements, the actual processes, how it should be funded, et cetera, can come more into focus. That's kind of my take on this. There have been several themes, again, that have been coming up over and over again across all these meetings. And if we can highlight those and emphasize those, that's really then what I would say should shape the rest of our work. And again, Andrew has made a very good start with that interim report. He has, applied a very good framework to more or less organize a lot of this information that's been provided, as well as the recommendations, but always coming back to what those core principles are guiding our work. That's to me most important. And I'm not saying that, when you look at it in terms of our task, our charge, that's one thing. But from the charge is how do we accomplish what's been set out in front of us? To me, I think you begin with those core principles. So hopefully I'm making sense. But
No, that makes total sense to me. Ms. Schneider?
Thank you, Madam Chair. I want to add on to what Dr. Gaugler has said. At our last meeting, I took a few notes on some comments from Dr. Gaugler where he talked about having reviewed the first draft in line by line, I believe you said, Dr. Gaugler, and where we go from there. And you talked about some buckets, and I think that is a way for us to possibly consider our work and our process going forward. A bucket of administration, funding, coordinating entities, et cetera, and then a bucket for setting of priorities. And that, of course, has direct impact on what our recommendations might be. But I know for myself, and I would think for all of the members of the task force, we are not interested in recommendations that will simply be in a binder on a shelf. This has to be living, moving forward. And then you also mentioned another bucket that I really want us to focus on, and that is this whole tracking and evaluation. Now, that's going to be the metrics piece. I think that if we don't set some guideposts up for knowing and checking on how we might be succeeding with whatever we recommend, we essentially haven't spent our time very well. So those would be three buckets that Dr. Gaugler mentioned that I've had a chance to noodle over, and I think they're quite valuable for our discussions going on forward.
Okay, so I just want to make sure that I captured those three buckets. So you had admin, services, tracking. Is that correct?
Admin, priorities, tracking.
Okay. And I think when I heard priorities, I was thinking services. but
Right.
Okay. Is there anyone else online with their hand up? Okay. Ms. Foley, did you have comments?
Not at this time. I'm
Okay.
looking at my notes here.
Oh, that's right. Ms. Foley, you take awesome notes. I love your notes. So I have also been thinking about buckets and how we do this. And we have heard over and over in our committee that there needs to be a single entity looking over the coordination between the different agencies. And what that entity would look like, I think we still have discussion to do. But I've been thinking about those buckets, in the thoughts of services and supports. We need to think about how do we do policy and planning and the economic piece of that. And then also thinking about what is aging in community and what are those supports and services and what does that look like? And Ms. Schneider, you and I have had many conversations about we have many good pieces that are working well, and it's not about breaking down things that are working well. It's about figuring out how do we get to that space where, as you said, there is accountability, there are measurements, there are metrics that we can see working. And we've identified a lot of good work that is currently happening in our state. But boy, oh boy, do we have some places where we're not really prepared based on testimony. And so, coming up with that entity that really will be the charge of, or the unit of state government that is responsible for aging, I think will be one of our core tasks that we have to do. Dr. Gogler, comments on what I just said?
No, I think it very much is in line with what we've been discussing, certainly over the past few meetings. Thank you to Ms. Schneider-Maureen for bringing up some of the points I made last time. You couldn't have said it any better than I could. You said it much better, actually. But yeah, I mean, I think we're starting to see the shape of what this report will look like, and most importantly, what some of its final recommendations will be. One thing I don't know, when you talk about, again, I've been hammering this over and over in these meetings, the importance of implementation and evaluating the success of implementing the recommendations over time, and if necessary, recommending that resources are put to support that. I'm not sure if we want to go as far as specifying what those metrics of success are at this point. We certainly can try. I mean, that would be an ideally, but I think this is such a large topic, it might be hard for us to wrap our arms around, saying specifically, we would like to see X% or some number, some metrics of success in the next 5-10 years. I'm not sure if we want to go that far, but at the very least, emphasizing as a recommendation the importance of supporting an infrastructure to allow that goal setting, metric, evaluation, establishment to occur, to me is very important too. So yeah, basically, Chair, what I'm saying is I agree with everything that's been said, and what I'm starting to see is now we're starting to get to the point where we're starting to put in some details here of what this final report will look like.
Yeah, and I want to give credit where credit's due. The buckets that I'm referring to have been formed with public input, right? These are the things that I'm hearing from the public. I think it would be not wise of us, Dr. Gogler, to think that we are knowledgeable enough to put all those metrics into place. I'm very comfortable with my own ignorance. Yeah.
Yeah, well, Chair Cleaver, one thing I think that's important to think about here when you talk about a metric of success or outcome or whatnot, one of the most exciting programs that I think the state of Minnesota put into place over the past decade or so with residential long-term care providers was called the PIP program. I forgot what the acronym stands for. It's Performance Improvement something. And why this program was so interesting to me was funding was provided for the long-term care providers to apply for. But when they applied, they were able to identify their own, what they felt were their goals that they wanted to achieve. And in a way, it allowed for a much more flexible program that fostered a lot more innovation than if it just kind of was a more traditional top-down, we're going to give you funding, but you have to do X, Y, and Z and accomplish X, Y, and Z. And it's very much in the spirit of what you're talking about, where in the end, I think communities themselves are best positioned to identify those metrics of success. And maybe, again, when thinking about the spirit we want to infuse this final report, and maybe that's what should be emphasized, is really metrics of success should be co-designed, co-created by the communities that are most affected by these programs or could most benefit from these programs.
Yeah, and I think it's interesting when we think about that co-design, co-creation, to also have full information. I mean, we've heard over and over how many of our state and federal dollars are actually funding a lot of private work that is happening. And we don't have a full picture because those are private entities. And even when it's nonprofit, when I look at the 990s, there's a lot of information that's not there, even though it is the full transparent process they have to report. So thinking about, like the question I asked today, who actually owns the facility, right? And what are the structures within those entities? And I'm not picking on the entities that were here today. But I think about, what's the for-profit side and what's the nonprofit side that is providing the care. So, how is the money coming in and who's providing the money coming in for, and I'm just talking about the care situation at this moment. And then who's actually receiving those final cash payments.
Yeah.
And what does that look like? But then, as we're thinking about our work, you know, I keep hearing the public's voice that so many of us live in our homes independently. And so what is the mechanism that we have to make sure that they have the transportation to get to their jobs? Are the accommodations in their jobs available so they can continue to work and the state can benefit from that mutually beneficial arrangement, right? And so there are lots of pieces that we have to think about, but I want us to think about it in terms of maintaining vibrancy, maintaining structures, and then when care is needed, what does care look like? Yes, Ms. Schneider?
Thank you, Madam Chair. Going back just to the basic question about the entity, I do want to continue to point out to the task force that at the present time, the Minnesota Board on Aging is the state unit on aging.
Yep.
And so the Older Americans Act dollars flow to the Board on Aging, and then we allocate them out to our 7 area agencies on aging across the state. Now, the Older Americans Act dollars provide for sometimes softer services than what you might obtain through the elderly waiver or alternative care. They also, when you actually look at the metrics, they are actually more affordable. They go further. Their cost per unit is less. We can serve more people with them. So I want to keep us remembering that, because where the Board on Aging is co-located within the Minnesota Department of Human Services, the Aging and Adult Services Division, that actually is a very convenient co-location because we butt up against the Medicaid dollars. And so there have been some economies there in terms of being able to share professional expertise, staff, and other things. So just something that I think we have to keep as a basic fact in our mind is we do at present have a state unit on aging, and it is the Board on Aging.
We do. And, you know, everybody in this room knows I'm very comfortable with conflict. So yes, as we do have that, the co-location also is a conflict of interest. So for me, it's not whether the Board of Aging is a good or bad entity, but to make sure that the Board of Aging is able to do and recommend and push forward. Because in the co-location, there, in my mind's eye, and we can have this full-throated conversation in committee, there are places where the board may wish to go one direction and the commissioner may wish to go a different way. And I have no example that I'm thinking of in my mind. I'm just thinking about clear channels and clear workflow, right?
Thank you. And you know, you're not going to get any argument from me regarding the need for clarity in all of what we're talking about here. That's absolutely true. The other thing I think that has been so strong on me is the value, the actual treasure of what we've gained from those folks who have testified and the organizations, the public and the various agencies, et cetera, et cetera. And I don't quite think, Madam Chair, that we are done hearing from various testifiers. I was thinking about this over the week, and I thought about aging and its connection to spirituality in a family, but we've not heard anything from Council of Churches, faith communities within the Judeo-Christian community, our friends in the Muslim community. These are folks who are dealing every day with congregations and families, and so I'm wondering about that. The other piece that I think we might have shortchanged ourselves a little bit on is, and it's not for lack of trying, but I would have liked for the area agencies on aging to be able to tell us a little bit more about what they're doing. When we have a quarterly changeover like we had at the end of June, I read a lot of quarterly newsletters from area agencies on aging, And I wish that our audience could know a little bit more about some of the remarkable programming that these area agencies on aging are putting out for consumers, for professionals. Maybe I'm a consumer who's about to enter Medicare and I don't know one single thing about it. I can go to a no-charge hybrid version tutorial and I can get what I need to at least open the door. And so I'd like us to be able to hear a little bit more. I read Trellis's newsletter this week about their Changemaker program and Dementia Friends. They're doing incredible work. And I think we ought to be able to let them tell us a little bit more about why they're doing this. They're doing this because their goal is to be responsive to the areas in which they serve. So that's pretty important. And then I think I'll stop there. Let's, if we possibly could, hear a little bit more from area agencies on aging. And again, Mr. George, I know that this has been something you've tried, but I could maybe even help with the Board on Aging, putting a little bit more pressure there.
And I think, Ms. Schneider, you're bringing up one of the issues that we have faced, and in trying to figure out where the gaps in services are. We also found that there is a gap in communication overall, right? So to Ms. Foley's question today, how would an individual know that there are entities that could do needs assessments, right? Or do I even qualify for services? Who do I go to? And I think our AAAs are awesome. They do really great work. Our counties do good work. Our senior linkage line does good work. And but this whole communication piece, right? What is the simple thing that we can recommend that would get that communication out, because that work, right, is critical. And we are, as a state, making investments there. So let's find ways to let ordinary Minnesotans know about it. And then when we're thinking about the linkage line, what are the things that we can do, either in our recommendations to say, this is how we keep it up to date. This is how we make sure that it's appropriate for your area, right? I think that whole communications piece is a recommendation that we could make. Ms. Schneider.
Yeah, thank you, Madam Chair. And I'm going to take it even a step further, because I believe in Minnesota, we have done a very great job in building our services and building our home and community-based continuum. And of course, we've had some challenges along the way. The pandemic certainly didn't help anything. Now we're faced with some labor shortages, which I have some very serious concerns about. But I think it's really, it's communication, but it's bigger than that. It's information and it's awareness.
Yes.
And that's one of the reasons I like Jen Foley's questions so much, because she puts them so often in the first person, which is, what about if I needed to do something? How would I go about? What would be my first call? What would be my first thing? And so in my mind, I feel like if we're going to move forward to continue to be a leader in aging among the states, and maybe internationally, we're going to have to continue to be intentional about making aging a household word. I don't know if that's going to be a spokesperson that no one can deny. I don't know if it's going to be tax credits. I don't know what it's going to be. Maybe it's loyalty programs. There are a number of options that we could look at, but we simply have to make it a topic that is a dinner table, around the family, of ongoing discussions, so that we quit denying the fact that we're all getting older and start enjoying what we can do to maximize it.
Yeah, and I agree with you. And to your earlier point, I don't think I mentioned that when you talked about bringing in faith leaders, I just think about who are those community leaders, right? Whether it's the faith community, the cultural community, who is it? Who has that ability in all of the different cultures that we celebrate in our state to get the information out, and to let people know that their voices are important and that there is a space for them in all of the aspects of our society, right? So what does that look like through the aging continuum? And I think we need, to your other point about, we are all aging. I mean, I don't know anybody who gets up in the morning and says, I hope this is the day that I expire. You know, that most of us don't think that way, right? So we do hope to get older every day, right? And if we are fortunate enough to live a long life, we want it to be a healthy life and a vibrant life, as long as we can make that possible.
And I think also we want to celebrate the fact that along with that long life then comes wisdom and experience. And I am not in favor of ending a resource anytime before its natural lifespan. So I want that knowledge, I want that experience. I want it to be well respected and sought after.
Yeah, and as we heard from Dr. Casey, is that how you say it? Caskey, we have more older people than we have young people. So we need to make sure that we capture that wisdom and that knowledge and allow people to have meaning and purpose in the process, right? Is there any further discussion online? Okay, I don't see any online. We are at just a couple of minutes for our time. I thank you all for being here. Our next meeting, Mr. George.
Thank you, Madam Chair. Our next meeting has been finalized for Thursday, I believe, July 25th at 10 a.m. I just heard from the Senate sergeants in this room, capital G23. Okay. More discussion for that meeting as well on what we're going for recommendations.
Thank you, everyone, for being here. I would like to remind the public that we are more than happy to accept your recommendations for what we need to be doing as a state. The Legislative Coordinating Commission has a Legislative Task Force on Aging website portal. We would love to hear your experiences. If you have a plan that you would like to submit, we would like to have that. And in our discussion about planning going forward, we do hope to have lots of voices in that discussion and to hear what people have to say about that. So with that, members, I believe that our business for today is concluded and we are adjourned.